Hi, good afternoon, everyone. Thanks to the chairman for the introduction. My name is Chang Yin. I'm a nephrologist by training with a special interest in critical care nephrology. So today, I'm just going to touch on a few pertinent topics about fluid management in the critically ill. As you can imagine, this is a very, very big topic. So we will have to be able to just touch on the evidence and just food for thought while you have your lunch. So this is the outline. I'll talk about the initial resuscitative period in terms of fluid resuscitation. And following the initial stabilization of the patient, what we do after the initial resuscitative period. Some methods of assessing the fluid status, and finally about fluid removal. The focus would actually be on patients with sepsis-induced hypoperfusion syndromes. Obviously, some of the evidence will not be applicable for other forms of shock, for example, cardiogenic shock, hypovolemic shock, trauma. Okay, the system's not too responsive to it. Okay, for the initial resuscitative period, the primary goal of fluid resuscitation will be to restore end organ perfusion. We all know that, and in the better days, we could just simply pull out this thing called the early goal-directed therapy, just run through the flow chart, get your CVP targets, MAP targets, and if you do the SCVO2 monitoring, then you just go for these targets. But life is now different. In fact, with more evidence, it becomes a bit more difficult. Okay, it became more complex when we actually had more information. So it started with the publication by this multi-center trial done in the US, where they compared between the early goal-directed therapy versus their own standardized protocol and versus physician-led usual care. And when they look at 60-day mortality, there was no differences. And then came the ARISE study, which was conducted in Australia and New Zealand, 51 centers, 1,600 patients. And again, there was no differences comparing between the early goal-directed therapy, following the protocol strictly, versus the usual care. No differences in the 90-day all-cause mortality. The PROMISE study came subsequently, conducted in the UK. Also, no differences seen at 90 days. So these three studies were actually called the killer trio of the early goal-directed therapy. But let us look more into details at each of the three studies. Before randomization, the patients were already given fluid. So the median fluids that were given for the patients is already in a range of 30 mL per kilogram. This was prior to randomization. Following randomization, there will be some differences in the usual care group. They did have less amounts of fluids that was given in terms of fluid resuscitation. But if you look at the overall volume, it is actually still quite high, irregardless. Okay, so what the main variations in all these three studies, the main variations were actually in the inotrope use and the red blood cell transfusion. There's actually less inotrope use and less transfusion in the usual care group, because if you don't follow, if the protocol, if you implement the early goal-directed protocol very strictly, you'll be trying to chase the MAP and also trying to chase the SCVO2. SCVO2 is chased using blood transfusions. So this is what I find to be the main differences in terms of comparing early goal-directed therapy versus usual care. So based on other studies came the updated consensus, the surviving sepsis guidelines published last year. So the work group still recommended at least 30 mL per kilogram of IV crystalloid fluid, and this is to be given within the first 3 hours. It is important to note that it's moving by itself, so I'm getting a bit confused. Is someone pressing the mouse button behind? Okay, so the original early goal-directed protocol, what you have from Rivers et al. Published in NEJM, no longer has a supportive evidence base. But the work group still felt that there's a need to provide guidance. And actually, the initial resuscitative fluid of 30 mL per kilogram over the first 3 hours Although there were some differences, if you look at the 3 studies, it actually showed that this is usual practice because it's actually inbuilt into the protocol in itself. Or the physicians themselves, although not limited by the protocol, also went on to give the same amount of fluids. There's also some older observational evidence that supports this practice. So at this point in time, the initial resuscitative fluid volume is still taken by consensus to be at 30 mL per kilogram. With it comes the Surviving Sepsis Campaign care bundles, 30 mL per kilogram of crystalloids within the first 3 hours, and at the end of 6 hours, we need to reassess the volume status and tissue perfusion. So this is table 1, which suggests that we should reassess the volume status and tissue perfusion, either using a repeated focus exam, that means clinical examination looking at the vital signs. Okay, see if this works. Vital signs, capillary refill, the pulse, and as well as looking at the skin turgor. Or at least 2 of the following, using either the CVP, SCVO2, based on your own clinical experience, bedside ultrasound, or any form of a dynamic assessment of fluid responsiveness. And within the campaign bundle, it actually recommended either using a passive leg raise or the fluid challenge. So beyond the initial resuscitative fluid, where we know the first 6 hours is the most crucial for the patients, what do we do after that in terms of fluid management? We look at a few trials that look at the post-resuscitative period, the first few days after the resuscitation. The first study is the vasopressin in septic shock trial, the VEST study cohort, 778 patients. By day 4, the average fluid balance was a positive 11 liters. The authors reanalyzed their data, and they divided the patients according to the quartile, the first to the 4th quartile. First quartile having the lowest cumulative fluid volume, while the 4th quartile had the highest cumulative fluid volume. And there was actually a higher mortality with the 3rd and the 4th quartiles, suggesting that a higher positive fluid balance in the post-acute resuscitative period is harmful for the patients. Another study, very well known, the FACT study, which also looked at the different types of fluid regimens post-acute resuscitation. So a liberal fluid had a positive balance of about 7 liters, while a conservative fluid strategy is almost a neutral fluid balance. Here is a negative 136 mils. Looking at the survival, no differences in terms of survival at 60 days. And the conservative strategy had actually more ventilator-free days, although it did not translate to a difference in survival, but I think we'll all be very happy to have our patients being less dependent on the ventilator. Some slight differences in terms of the MAP, maybe a slightly higher creatinine with the conservative fluid management group, but that was not statistically significant. No differences in terms of inotrope requirements and dialysis support. So this also shows that a conservative fluid management strategy after the initial resuscitative phase will benefit the patient. Another study which also look at the post-resuscitative period. They divided up, it's a retrospective study with 200 over patients. They divided the patients into 2 subgroups. One is the initial fluid resuscitative groups, where they divided the patients into adequate resuscitation and inadequate resuscitation. Adequate being an initial fluid of at least 20 mils per kilogram and targeting a CVP of more than 8. This was in the days where the early goal-directed therapy was still very much recommended. And they looked at also the subsequent post-resuscitative fluid management. A patient is considered to have undergone a conservative late fluid management if they have even to negative fluid balance for more than 2 consecutive days in the first 7 days. So the highest mortality is actually seen with patients who have had liberal late fluid management. That means they have much more fluids in the post-resuscitative periods. Even if you look at those patients with inadequate initial fluid resuscitation, a conservative fluid management strategy actually gave a comparatively better survival comparing to those who have had liberal fluid intake after the initial resuscitation. So this suggests that a conservative fluid management, if you're looking at all these trials that we have just looked at, it may optimize the chances of patient survival. So this idea was actually of fluid management was actually promulgated by Goldstein, who is actually more involved in terms of pediatric work, but I suppose it also applies to the adult population as well. So there's an initial resuscitative phase, and we have come to expect that there will be a positive fluid balance as we use fluids to try to improve the patient's and organ perfusion. But in the subsequent maintenance phase, we should aim to maintain hemodynamics without getting the patient much more fluid overload. And finally, the recovery phase, if the patient does not recover by itself, let's say the kidney function improves, the patient will be able to diurese on its own. But if that doesn't occur on itself, we will have to think of ways to remove the excess fluids. So comes the next part about fluid status. In order for us to decide whether or not we want to give the patient more fluids, or in order to decide if we want to actually offload the patient from the excess fluids, we actually have to have a way to assess fluid status. At this point in time, it still remains a clinical judgment. Nothing beats a physical examination, looking at the patient's overall picture for us to decide. But there are some other ways that we have always tried to make it less subjective, try to make it more objective. But it so turns out that all the static measurements of CVP, of the right and left heart pressures actually do not predict any response to fluid challenges. So in the literature, what we have that is actually correlates better to a subsequent response to a fluid challenge or actual infusion of the fluids will be dynamic measures. And what is recommended in the surviving sepsis guidelines and what has the best body of evidence would actually be the actual fluid challenge in itself or a passive leg raise. We all like the idea of a passive leg raise because it's an immediately reversible fluid challenge. You lift up the legs 45 degrees and it's about a 300 mils fluid challenge. And if there is no response by the patient, once you put down the leg, the patient is actually not in any form of positive fluid balance. And we have already seen that a positive fluid balance will be detrimental to the patients in the post-resuscitative periods, in particularly for the patients who are still clinically very unresponsive, and we can't keep giving actual fluid boluses to the patients in order to look for fluid responsiveness. Bearing in mind that this has to be against stroke volume measurements rather than to just look at the MAP or the blood pressure on itself. So other ways would be also to look at the stroke volume changes or sometimes pulse volume variations if there's any, in response to any changes to the intrathoracic pressure induced by mechanical ventilation. So this is some evidence supporting the practice of a passive leg raise. We have quite a few studies that actually showed very good correlation to a subsequent fluid challenge and how the patient's responds to it. If you look at the AUC curve, it's very, very impressive. The AUC is actually 0.95, very near to 1, suggesting a very good correlation that a positive passive leg raise would eventually suggest that it will predict that the patient will respond to an actual fluid challenge in itself. And also in this study, a meta-analysis, it also found that the best threshold to predict response to fluid challenge would be the passive leg raise and increase in the stroke volume by more than 10%. So that was an adjunct for us to decide if the patient needs more fluid. So on top of a clinical assessment, perhaps a passive leg raise if you have access to stroke volume measurements. So that will help guide us whether or not to give the patient more fluids. But how do we decide if the patient has already been given too much fluid? We can look at the pediatric data, and most studies that shows that if a pediatric patient has more than 10% fluid overload, and is calculated with the formula at the bottom, if they have more than 10%, it is associated with an increase in mortality. So this is one of the studies that has been included in the analysis, and it found that the increased mortality in children if they have a fluid overload of more than 10%. Another study, this is in the adult population. The PICARD study is actually a multi-center observational study, and they looked at the post-hoc analysis of 610 patients with acute kidney injury. Patients with less than 10% fluid overload versus patients with more than 10% fluid overload, those with a higher accumulative fluid overload had actually a higher risk of mortality as well. So it seems that this cutoff point of 10% fluid overload may be used as a guidance in order to decide whether the patient is too overloaded or not. And this is one more study that shows that for every 1% increase in the percent fluid overload, the 1-year survival actually decreases further. One interesting point that also came out in this study, that patients who did not recover their renal function had actually a higher percentage of fluid overload. So if we have found that the patient is fluid overloaded, how do we go about removing the fluids? We have come to accept that in all our resuscitative protocols, in all the usual care, either a resuscitative protocol if you follow the EGDT very strictly, or even in the usual care practices nowadays, a very high initial IV fluid volume will be administered. Original river study, 13 liters at the end of 72 hours. You look at a more recent randomized control trial, so PROCESS study, positive 4.5 liters already at the 6th hour, and this is in the usual care arm. ARISE, as well as PROMISE, is also in a range of positive more than 4 liters at only at 6 hours. This was the VEST study, which I went through, and by day 4, the median positive balance was 11 liters. So we do expect in the initial resuscitation, IV fluids will be administered. So how do we remove the excess fluid that has accumulated over the days of the initial resuscitation and subsequent maintenance? While diuretics in these few studies have been shown to increase the amount of fluid clearance, but there's actually no effect in terms of outcomes, the hard outcomes such as mortality. And in fact, one of the studies by Ravin Mehta actually showed an increased risk of death with diuretic use. I suppose in a patient that is already critically fluid overloaded, and if you just say, oh, let's shoot in some Lasix and let's wait a while, it will probably lead to worse outcomes in the patients if you wait further. So if we can't use diuretics, if the patient is not diuretic responsive, the option would be to start the patient on some form of dialysis. Usually when we want to start on dialysis, we think of the timing, intensity, mode, and dose. In the interest of time, I'm just going to cover timing and intensity. There's been a few recent trials about timing of the randomized control trials, these 3 trials. The first is the START-AKI, it's a pilot study comparing starting dialysis at the early stages of stage 2 AKI versus starting when there's indications. And they found no differences in terms of survival, whether or not you start early or you start late. The other one is the ELAINE study, comparing when the patients are initiated on some form of RRT 8 hours into stage 2 AKI, or the first 12 hours of stage 3 AKI, or when there's marked indications for RRT. And in this study, they found that there's actually an increase in mortality with the delayed therapy. The largest study was the AKIKI study, published in the NEJM, and they compared the early part of the starting dialysis in the early part of stage 3 AKI, or when there is subsequent indications. And in this study, it shows that there is no significant differences. So this is very, very confusing. So do we start early? Do we start late? So what I would suggest is, let's take away all this, and instead of looking in terms of the AKI staging, we look at the differences comparing between AKI onset and the indications, whether or not they are present. So we have the START-AKI and the AKIKI study, which actually showed if you start renal replacement therapy at the onset of a diagnosis of AKI versus starting when early indications are present, there's no differences in mortality. And then we look at the ELAINE study. The inclusion criteria demands that the patient must have stage 2 AKI, and on top of that, they should have at least one of the following: severe sepsis, high dose of noradrenaline, refractory overload, worsening APO, a low PF ratio, and a high percentage fluid overload, and a SOFA score of more than or equals to 2. So these patients actually had, some of the patients would already have indications for starting dialysis in our normal clinical practice. But if you waited further and wait for some further absolute indications, this actually gave us a higher mortality that was observed in this study. So in terms of this, it suggests that overt fluid overload, refractory to treatment, is actually accepted as a clear indicator for us to start RRT. So this is, in terms of timing, the fluid status is actually one important parameter to look at. How about intermittent versus continuous modes? So there have been many RCTs, so a lot would just say, oh, there's actually no difference if you compare between CRRT and the intermittent hemodialysis modes. So these are a few of the studies. But actually, if you look at the inclusion criteria, the studies actually routinely exclude the most unstable patients. So these patients will actually be pushed towards the CRRT arm, or the physician will say, no, 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 I can't randomize this patient because I will want the patient to go on the CRRT arm. So for the remaining patients that got included, there's actually no significant differences. There's also some studies that actually allowed the crossover, which is a COVID study, which I'll talk about in a few more slides' time. So back to this Picard study, and they went on to look at the different types of modality of dialysis. And the CRRT was actually able to reduce this percentage fluid overload. And at the end of 10 days, it managed to bring the patient down to below 10%, while patients on intermittent hemodialysis actually had a cumulative fluid overload. One more study comparing, another RCT comparing between intermittent and continuous therapies. And the CRRT actually resulted also in more negative fluid balances over intermittent hemodialysis. In the 2-3 years back, we have this COVID study, which was the most recent RCT comparing between intermittent versus continuous hemodialysis. 2 arms, intermittent hemodialysis, 128 patients versus 122 in the CVVH arms. And the mean daily ultrafiltration rates actually show no differences. So a lot of people will quote this study to say, oh, you see, no differences. As long as I just crank up the volume of the intermittent hemodialysis, I'll be able to get what I want. Of note, there's also no differences in terms of 30-day survival between the CVVH and IHD. The continuous therapy actually had a trend towards a higher survival, but it was not statistically significant. But if you look at the protocol, there's actually, written in the protocol, they allow a switch of modality. About 20% of the patients switch from intermittent hemodialysis to continuous RRT, while half the cohort actually switched from continuous therapy to intermittent hemodialysis. So they actually, in the study, most of the switch from continuous to intermittent is because the patients got better and more stable, so the study group switched them over to intermittent hemodialysis. But the analysis was actually done based on the intention to treat analysis. If you look at the reasons for switch from intermittent hemodialysis to CRT, is basically because the patients were more unstable, or if the patients developed a significant fluid overload. So although this showed that there was no difference in the UF volume, but it actually suggested that CRRT is the modality to go to if you require more fluid removal. So in conclusion, a fluid resuscitation and a more aggressive fluid therapy is actually indicated in initial management of the patient. Until we have more studies to show us otherwise, this now appears to be the standard of care for our patients. And following the initial resuscitative phase, we should hold back on the fluids, and a more conservative approach should be taken. The fluid requirements should be determined clinically with some indicators, if available, to help us to see whether a patient either needs more fluid or if it is time for us to start removing excess fluids from the patient. And in the absence of any renal recovery, we have to consider renal replacement therapy. And perhaps it would suggest that continuous therapy would allow more fluid removal, but this would depend on, of course, the patient's status. Typically, the patients who are more ill would be more overloaded, and you will actually need a continuous form of therapy to ensure that the fluid accumulation does not occur. Okay, so I've attached my email here for anyone who wants to ask me questions subsequently. Or if anyone would like to ask some questions here, we can